data repositories in identifying targets for sustainability. And so, Dr. Razak, for 6 minutes, and here's your clicker.
All right, I'm putting a timer on because I'm afraid of you. Great to be here today. My timer has started, so I'm not going to do the pleasantries. I'm just going to go. No, wrong way. Okay, so I am not someone who has a lot of experience in sustainability and climate-related work. I've had the great privilege of working with Miles and others. My work is on digital data structures, and I wanted to talk to you about potentially a really exciting opportunity because of advancements in these structures. So historically for Canada, we had probably about 50 to 100 data points on every healthcare encounter that happened in hospital. This would be very high demographic data, very limited demographic data, age, sex, why a patient was hospitalized, whether they died or not. That was it. But in the last decade, 15 years, I would say, we've had very rapid digitization of the healthcare system. So now more than 99% of all information generated in a healthcare encounter is this deep clinical data. And it includes things like unstructured clinical notes, which have huge amounts of information about the way that individuals are living, what kind of social situation, frailty, other areas. Digitized vital signs, transfusion information. As you know, transfusion is a very labor and resource intensive process to develop even 1 unit of red blood cells. All of the imaging tests, again, I don't want to emphasize over and over again, these are highly resource intensive tests that we have to generate. Medication data, all testing that's done in hospital, details on the physicians, so you can think about variability at the physician level, and then operational data of software. Operational data from hospitals. This includes wait times in hospital, wait times in hallways, what kind of cleaning is being done. So a lot about sustainability, and the delivery of healthcare is now digitized and available. I co-lead the largest platform in the country that pulls this information out of different hospital systems and makes it available for analytics. We've written a lot of academic papers about how to do this with high accuracy. The high-level summary is that on a random audit now, we can get highly precise information. This is a random audit of over 23,000 data points. We can get highly precise information about these very detailed elements of healthcare delivery at scale. So as you can see, the accuracy is 98 to 100%. This is being used extensively for research. So as I mentioned, the footprint of our platform covers 25% of all of Canada's hospital beds now, all of Canada's adult medical beds. A recent investment by the government of Ontario means we have 80% coverage of all of Ontario's pediatric beds, which means about 40% of the entire country's pediatric beds as well. We have high performance computing on site. This is sensitive information. This is, for example, an HIV diagnosis or cancer diagnosis for an individual person, all of it non-consented because it's being done at scale. So it's within this very secure environment with data already on more than 3 million Canadians' hospitalizations, billions and billions of data points, supports a lot of innovation research. It also, importantly, is the basis of a customized quality delivery program where every physician now covering 60% of the province receives highly detailed reports. You can imagine a future state where you start to embed parameters around sustainability metrics, and hospital executives also get reports. This is a screen grab of one of those reports where you can see now very detailed information at every individual physician level saying, here's how you're practicing, here's how much blood work you're ordering, red blood cell transfusions, medications, whether those medications are intravenous or oral. These have major implications on resource use. And the same thing now at the hospital level to allow hospital executives to see that. So huge amount of digitized data produced now in every healthcare encounter. It doesn't cost more money to produce it. That information now is securely available for analytics right down to the physician level or the hospital level. Okay, so what is the relevance for your work? So excited to see this paper. I'm sure many of the people who wrote this are in the audience today. I've had that great privilege of working closely with Nava and Billy and had meetings with Owen and Miles before. And this was a statement for the kind of medicine that I do, which is called general medicine. This is 40 to 50% of the entire hospital's admitting volume now goes to just one ward called general medicine. I'm at St. Mike's, is where I practice. And what they recommended here, this is a hot off the press 2025 paper, they looked at what they consider to be the top sustainability targets within the practice of medicine on these general medical wards. And here's their list. So they said, don't prescribe intravenous antibiotics when you can use an oral option. Don't prescribe heparin. Heparin is a very intensive medication for us to prescribe when you have an oral alternative. Think about the way you're delivering bronchodilators. Don't use greenhouse gas intensive metered dose inhalers when you have these clear alternatives for the way that the drug can be delivered. Don't recommend interventions for people with limited life expectancy. For example, if someone is palliative, then why use a labor greenhouse intensive intervention, which probably doesn't advance their care and also has all of these indirect side effects. Don't continue medications without considering clinical indications, and they pick sedative medications, proton pump inhibitors, inhalers. Don't routinely order daily blood tests if a patient is stable. Don't use sterile disposable gloves when hand hygiene is sufficient. And don't book in-person follow-up appointments when a virtual visit is clinically appropriate. And if I would look at our data set, all of this can be quantified except for one thing. Already today, not a future state, but today we could tell you for each of these recommendations, the medication and the route, the medication and the route, the medication and the route. Whether a patient is palliative, this is all digitized. More information about the medication and alternatives, all of the lab testing information, including whether a patient is stable, and also where the appointment location occurs, whether it's virtual or in person, if the patient is sick enough to require an in-person assessment as opposed to virtual. And my timer is going off in 3 seconds.
Beautiful. Thank you so much.